Good afternoon once again. We'll be talking about PC rent in a topical phaco. As we know, we would have planned the best for the patient, probably even a multifocal or a premium IOL implant. But when a rent happens, it happens. Okay, and the more number of cases you do, the more number of rents you have. And experience plays of course a part, but then this is part and parcel of the game. So the same happens in topical phaco also. So no financial disclosures. So the most important thing we need to do is do not panic. Like Bobby McFerrin sang, when you worry, you make it tumble. So don't worry, be happy. So if you struggle, if you get tensed up, there's no point, you can only make it worse. Anyway, you have to face the situation. Anyway, you have to go ahead. So take a break, take a deep breath, and continue with the surgery. So before we go into that, I will rush through the causes. So it could be a peripheral extension of an AC tear, which has already, that must have been a rhexis run out, where obviously you would have been careful, or some areas of the rhexis may be weak, which you wouldn't have really noticed. And this would happen, it will just give way. It may look very normal. That's why I always say override the edge of the rhexis from the area where you started when you ended. So that will give better stability. As you know, the circular nature and the continuous nature of the rhexis is what gives it all its strength. Damage from a second instrument, especially a chopper, you usually can chop the rhexis margin. This can cause extension posteriorly, wraparound tear of the rhexis tear. Aggressive phaco, like in going too peripherally, pushing the nucleus, etc., etc. Aggressive settings, which is inappropriate for the kind of cataract you are dealing with. Okay, using very high parameters in a soft cataract, etc., or even very low parameters in a hard cataract. And when you have a posterior polar cataract, post-vitrectomy, post-intravitreal injection, nowadays, most of us are also giving intravitreal injections, the anterior segment surgeons. So we have to be careful that in those cases, there could be a possible posterior capsular touch and a problem. And so this is what I mean by aggressive phaco. Yeah, the person is going too peripherally and pushing and trying to pull it, and then using very high parameters, and the way he is applying the energy, it is rolling around, and ultimately at the end of the day you are having a big rent. Okay, now you see the rent is caused. Now it's in a very, very catch-21 situation. Now bevel down phaco, especially in a soft cataract, you should never go bevel down, especially it will eat up through the epinucleus and straight into the PC. Now you see there is a capsular rent. So what are the warning signs? Okay, whenever the nucleus stops rotating, you have to take it as an indication that there is a PC rent and vitreous is getting engaged. The AC deepening, sudden deepening of the pupillary snap sign, the heminucleus decentration, that means it's slightly sinking down, vitreous strand, or at the end drop lens fragment. Don't ignore any of this. Obviously the drop lens fragment you won't ignore, but the other things your ego may come in the way and you may try to do something stupid. So this is what about the nuclear rotation. See, the person is going deep. Okay, see there itself, you are going deep in the periphery. You can go deep in the center, but not in the periphery. Now he is intelligent enough to just try and separate and see. Not very clear because with so much of nucleus, it may not be very evident. See, now he tries to rotate. See, it is springing back every time. So this is a dangerous sign. And the sign of AC deepening, you see. Suddenly while grooving, there is a rent. Yeah, you see the pupil snapping and also the AC becoming suddenly deep. This is again a sign. And this is a dislodged heminucleus, sorry. So this is a dislodged heminucleus. At this time, if you try and do something, it is going straight into the vitreous cavity. So a drop can also happen like this. Yeah, trying to remove and suddenly see, again he is trying to manipulate and then the piece is gone and there's a big rent. So when you have to manage this case, you have to have cognitive skills and surgical skills. Both are very important. So always take a breath. Okay, never pull out of the anterior chamber. That's one big thing. Before you do all these things, whenever you suspect a rent, always keep the phaco probe there, going through the side port. Use something like viscoat, no financial interest. Try to block and make the rest of the pieces stable so that we can handle it later in a better way. And then when you are out, stop for a while, think about what happened, look at the situation. Do I need to hand it over to a VR surgeon at this point? Can I go through the same size wound and continue with phaco? Or do I need to extend? Do I need to, visco express the fragments? This is very important. Take a minute or two and then go ahead. And regarding the surgical skills, do no harm. That's very, very important. So stabilize the fragments. Like I said, you go in with viscoat initially before you pull out itself. It helps in two ways. One is it stabilizes, blocks the PC opening. Second, it will not allow the PC run to extend, and it also helps to stabilize the other fragments. You also always do a dry vitrectomy, and then you can also use triamcinolone if necessary. Most of the nuclear matter is still in the eye. So you do the vitrectomy to get the pieces free so that you can visco express a large fragment. Always do a cleanup vitrectomy, IA. The choice of IOL depends on what stage it is. You can go in for a sulcus fixated IOL, or in the bag itself if it is it's a small rent, or you could make it into a posterior PC rexis, or SFIOL, scleral fixated IOL, or glued IOL, or the iris glow, which was discussed in the previous. You can always use a myotic, and you can have a final check with triamcinolone. Always respect the vitreous base. Dr. Reshma will talk more about this. Do not pull or prolapse any vitreous gel. Use low vacuum and high cut rate, simply because you don't want to pull the vitreous base. And this is what happens. In this case, actually there was a false alarm. Okay. So the surgeon goes deep, but then suddenly he sees a crack in the epinuclear plate. So what he does, he just comes out and then he puts visco and he tries to rotate. And when he rotates, it's easily rotating. He can go ahead with cataract surgery. But here there is an early fragment drop. So again, the surgeon is going to the periphery. See, it was not mandated. See, there itself, he should have thought about it. But then again, the ego. He tries to rotate, then tries to remove one fragment in this side. Somehow it comes out, and then he again tries to rotate. He should have learned by this time. Then he again does foolish things, and then see, there it goes. There is a the fragment drop. Okay, now, yeah, take a deep breath. Go this thing, come out, block it with visco. Try to visco express as much as possible, and always when you don't need bubbles, it comes. That is Murphy's law. So then orovisc becomes aerovisc, as Dr. Matthew would say. And then try to remove as much as possible. Visco express, do vitrectomy whenever it is necessary. And you can use irrigation aspiration with the vitrectomy probe itself. You can enlarge incision a little bit whenever needed. And then there's a lot of epinucleus that also can be gently visco expressed, making sure that nothing goes into the posterior cavity. Yeah, you can just glide it out, carousel it out. Yeah. And once you do all that, you can go in and implant a 3-piece hydrophilic acrylic into the capsular sulcus, into the sulcus above the capsule. And if you carefully place it, nothing will, it will be very well centered. You should always be very gentle in the manipulations. Okay. Don't extend the tear. And at the end of it, you can use air bubble to see whether everything is fine, or you can use triamcinolone. Then you can do a vitrectomy, a PI with the vitrector, and this is how it looks at the end of surgery. Yeah, coming on to, if there are larger fragments, then obviously you will have to do some vitrectomy to loosen it out, and then you can remove it like this, and then you'll have to suture it. And yeah, this is again when there is a large fragment remaining, what you need to do. You can do a vitrectomy, loosen it up, and then gradually remove this without allowing it to, see, you can do a triamcinolone vitrectomy also at the end of it. And a PP vitrectomy, I am sure Dr. Reshma will talk more about it. Here there is a definite nucleus drop, and this is the PP vitrectomy being done and removed. And prevention, always avoid an undersized rhexis, which can cause problems in many ways. Avoid second instrument trauma and peripheral posterior or posterior phaco push. And PC rent in late phaco is because of post-occlusion surge, settings which are too aggressive. You continue with the same nuclear. You should always cut down on the phaco power as well as the aspiration flow rate and the vacuum. Bevel down phaco should be totally avoided. And here most of the time you can see the PC tear. For example, in this case, while removing the epinucleus, the person is too aggressive, and see, it's getting eaten up, and there is a rent which has happened. So in such cases, you have to be very careful. So again, recognize the complications, stay calm. OVD-BSS exchange, very important, stay inside the eye till you replace with OVD and tamponade the break. In case possible, convert it into a PCCC. Identify and remove the vitreous with triamcinolone, and the choice of IOL depends on the situation. And this is one such video in which you identify the rent and do a careful vitrectomy, and then you make sure the rent remains at the same size. And always after implanting the IOL, make sure that you put in tricoat and do a neat removal, so that you're sure there is no vitreous incarceration. So always use softer setting for the final fragment. Stay central. Don't go in this way, that way. Always be bevel up in these cases. And this is in essence how you manage rent in a topical phaco. Thank you very much for your patience.